The following educational video was created in collaboration with the Faculty of Biomedical Engineering of the Czech Technical University in Prague and the First Surgical Clinic of the General University Hospital. Break time. ECG decalogue. On the ECG curve we determine: firstly, the P, T, and U waves. Second, the Q, R, S deflections. Thirdly, the intervals P, Q interval and Q, T interval. Fourthly, the segments ST segment. The isoelectric line is a horizontal baseline on the ECG without vertical deflections. Under normal circumstances, short segments of the isoelectric line alternate with deflections that arise due to the propagation of the electrical impulse through the heart muscle. These include the P wave, the QRS complex, and the T wave. A persistent isoelectric line appears during cardiac arrest with immeasurable electrical activity. The ECG is recorded on millimeter paper. To correctly interpret the values, we must set the scale for 1 millivolt, which usually corresponds to an amplitude of 10 millimeters. The standard paper speed for recording EKGs is 25 millimeters per second. When interpreting an EKG, we follow the 10 commandments that evaluate firstly, the regularity of the heart action, whether it is regular or not. Secondly, the cardiac rhythm. If every QRS complex is preceded by a P wave, we speak of a normal sinus rhythm. If the impulse does not originate in the sinoatrial node, and the P wave does not precede each QRS complex, we do not speak of a sinus rhythm. Instead, it may be pathological rhythms where the impulse is generated, for example, in the atrioventricular node, the atrial muscle, or the ventricular muscle. The P wave is absent in atrial flutter, atrial fibrillation, or sinoatrial block. Thirdly, the heart rate, which we calculate as 300 divided by the number of large squares between R waves. Fourthly, the P wave, its presence, size, shape, positivity, or negativity. It represents the electrical activity of the atria. Physiologically, the P wave precedes each QRS complex, from which it is separated by the PQ interval. Fifth, the PQ interval. Atrial contraction, atrial complex. The time from the start of the P wave to the beginning of the QRS complex. This represents the time from the impulse generation in the SA node, its conduction through the atrial muscle and AV node, until it reaches the ventricular muscle. Sixth, the QRS complex. Assess its width and shape. This reflects the propagation of the impulse through both ventricles. Seventh, the ST segment. Ischemic changes are described in all 12 leads, looking for elevation of ST segments above the isoelectric line, or depression, a decrease of the ST segments below the isoelectric line. Eighth, the T wave. We assess its positivity or negativity, shape and size. Ninth, QT interval. It displays the duration of the electrical activity of the ventricular myocardium from the start of the QRS complex to the end of the T wave. 10th, the heart axis. Normally oriented leftward, with the direction of the electrical vector during ventricular depolarization pointing from the right to the left. The electrical axis is not the same as the anatomical axis of the heart. 11th, extrasystoles. These can be atrial or ventricular. They can occur singly or in groups. They can originate anywhere in the heart muscle as a premature impulse. ECG interpretation should always be done in the context of the patient's clinical symptoms and other diagnostic tests to ensure an accurate diagnosis and treatment.